Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 190 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, MIM, a 44-year-old male patient was brought to your accident and emergency department. He has a chief complaint of severe altered mental status, confusion, fever of 38.4 degrees Celsius, and was hemodynamically unstable with severe hypotension requiring vasopressors. He was admitted to the medical intensive care unit. He has a past medical history significant for HIV infection and currently receives antiretroviral therapy, although he has been inconsistent in taking his medications. Because meningitis was suspected, MIM was started on intravenous IV antimicrobial therapy with cefepime 2 grams thrice daily, vancomycin 1000 mg twice daily, ampicillin 2 grams 4 times daily, acyclovir 10 mg per kilogram thrice daily, and liposomal amphotericin B 3 mg per kilogram once daily immediately following a lumbar puncture (LP) in the accident and emergency department, while awaiting results of cerebrospinal fluid (CSF) analysis. At this time, MIM's condition is stable, he is afebrile, and he has been weaned off vasopressors. He has no known drug or food allergies. His pertinent labs include a CD4 count which was done 1 week before admission of 100 cells per millimeter cubed, HIV viral load of 10,000 copies per milliliter. His CSF analysis results were as follows: opening pressure was greater than 200 mm. There was neutrophilic predominance, his CSF protein was elevated, and the CSF glucose was slightly below normal. A meningitis, encephalitis, ME, panel was positive for Streptococcus pneumoniae. His CSF gram stain showed gram-positive cocci in pairs NAD chains. His CSF culture is still negative to date. His serum creatinine is 1.4 mg per deciliter. At baseline it was 1.0 mg per deciliter. So my question to you is, which of the regimen changes listed below would be the most appropriate to make to MIM antimicrobial regimen now? Would it be A. Continue cefepime, ampicillin, and vancomycin. Liposomal amphotericin B and acyclovir should be discontinued, or B. Discontinue cefepime, ampicillin, vancomycin, acyclovir, and liposomal amphotericin B and start ceftriaxone alone, or C. Continue acyclovir and vancomycin. Discontinue cefepime, ampicillin, and liposomal amphotericin B, or would it be D. Continue liposomal amphotericin B and cefepime. Discontinue acyclovir, vancomycin, and ampicillin. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Discontinue cefepime, ampicillin, vancomycin, acyclovir, and liposomal amphotericin B and start ceftriaxone alone. because the patient has a blood culture with Streptococcus pneumoniae in addition to the ME-PCR panel positive for Streptococcus pneumoniae, and the CSF gram strain is growing gram-positive cocci in chains, a morphology consistent with Streptococcus, it is evident the patient has Streptococcus pneumoniae meningitis. The current antibiotic regimen is causing the patient harm, that is, acute kidney injury. Therefore, de-escalation to targeted therapy using ceftriaxone alone, instead of cefepime and without ampicillin, vancomycin, liposomal amphotericin B, or acyclovir, is appropriate, as the isolate is likely susceptible to ceftriaxone. The ME-PCR panel detects the presence of specific pathogens with high sensitivity and specificity, so the report of Streptococcus pneumoniae using this methodology is reliable for diagnosing the causative pathogen. The CSF analysis is suggestive of bacterial meningitis, with a high protein concentration, low glucose concentration, and neutrophilic predominance. Therefore, antiviral and antifungal therapy should be discontinued in this patient. The antibacterial therapy should be de-escalated to ceftriaxone because the isolate likely susceptible to this agent based on high likelihood the Streptococcus pneumoniae isolate to be susceptible, should base on local antibiogram. Vancomycin is no longer needed because ceftriaxone will provide adequate coverage of Streptococcus pneumoniae. Please advance to the next question. And the next question reads, concerning MIM above, the opening pressure from LP was greater than 200 mm, and the CSF analysis showed a neutrophilic predominance with an elevated protein concentration and a glucose concentration slightly below normal. A meningitis, encephalitis, ME-PCR panel revealed the presence of Streptococcus pneumoniae. A CSF gram stain shows gram-positive cocci in chains, but the culture remains negative. Final results pending. A blood culture obtained on admission is also growing gram-positive cocci in pairs and chains. Now, MIM's condition is stable, he is afebrile, and he has been weaned off vasopressors. He has no known drug or food allergies. His renal function is slightly diminished and his serum creatinine is 1.4 mg per deciliter, which is elevated compared with a baseline value serum creatinine of 1.0 mg per deciliter, possibly due to the recent antimicrobial therapy. So my question to you is, which of the options listed below is the recommended duration of de-escalated antimicrobial therapy for this patient assuming that no other pathogens are identified in cultures and day 1 of therapy is based on the day with the first negative blood culture? Is it A, 28 days, or B, 21 days, or C, 14 days, or is it D, 7 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, 14 days. This patient has confirmed Streptococcus pneumoniae meningitis and bacteremia. Guidelines for the management of bacterial meningitis recommend 10 to 14 days of antibacterial therapy, so 14 days of de-escalated therapy starting at the time of the first negative blood culture is the most appropriate choice. 7 days is inadequate, 21 days is excessive, 28 days is excessive. Please proceed to the next question. And the next question reads, TSB, a 57-year-old female patient with a severe subarachnoid hemorrhage was admitted to your hospital and shortly after admission an extraventricular drain, abbreviated as EVD, had been placed. A cerebrospinal fluid (CSF) leak developed 2 days after EVD placement, which necessitated the placement of a ventriculoperitoneal, abbreviated as VP, shunt. A fever of 38.8 degrees Celsius and noticeable drainage from the EVD incision were observed during the multidisciplinary round, which raised concerns about infection. The multidisciplinary team obtained a CSF sample for culturing and initiated TSB on empiric IV cefepime 2 grams thrice daily and vancomycin 30 mg per kilogram, followed by 18 mg per kilogram twice daily. 24 hours later, the CSF culture was growing vancomycin-resistant Enterococcus, abbreviated as VRE. The VRE isolate was found to be susceptible to daptomycin, intermediate in susceptibility to linezolid, and resistant to ampicillin. TSB's antibiotic therapy was switched to daptomycin 12 mg per kilogram IV twice daily alone. Repeat CSF cultures 4 days after starting IV daptomycin remain positive for VRE, and TSB remains febrile with an elevated peripheral WBC count. So my question to you is, which of the following is the most appropriate strategy to optimize the management of this patient's VP shunt infection? Is it A. Add intraventricular daptomycin 5 mg once daily, or B. Add intraventricular vancomycin 30 mg once daily, or C. Increase the IV daptomycin dosage to 15 mg per kilogram once daily, or is it D. Add gentamicin 1 mg per kilogram IV thrice daily for synergy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Add intraventricular daptomycin 5 mg once daily. A daptomycin IV dosage of 10 to 12 mg per kilogram every 24 hours is appropriate for the treatment of this patient's healthcare-associated bacterial meningitis caused by a pathogen susceptible to the drug based on its central nervous system penetration, so this patient is already receiving the optimal dosage. According to guidelines for the management of healthcare-associated ventriculitis and meningitis, direct instillation of the active antibiotic into the ventricles should be considered for infections caused by a multidrug-resistant pathogen. Daptomycin 5 mg intraventricularly daily is consistent with guideline recommendations. This is the best choice for this patient. Adding IV gentamicin to IV daptomycin is not appropriate. Adding intraventricular vancomycin is not appropriate for an infection caused by a vancomycin-resistant organism. Please advance to the next question. And the next question reads, which of the characteristics listed below should be sought to limit neurotoxicity during the selection of an antibiotic and dose for intraventricular administration? Should it be A. large drug volume, greater than 10 ml, and preservative-free formulation, or B. large drug volume, greater than 10 ml, and formulation containing preservatives, or C. small drug volume, less than 5 to 10 ml, and preservative-free formulation, or should it be D. small drug volume, less than 5 to 10 ml, and formulation containing preservatives? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. small drug volume, less than 5 to 10 ml, and preservative-free formulation. According to available literature on the administration of medications intrathecally or intraventricularly, a large drug volume, the presence of preservatives, and factors that contribute to a non-physiologic pH and osmolality, drug concentration as well as diluent, have been associated with neurotoxicity. Therefore, these factors need to be taken into consideration when selecting an antibiotic and dose for intraventricular administration. A small drug volume, less than 5 to 10 milliliters, and preservative-free formulation should be sought. Please proceed to the next question. And the next question reads, MAT, a 39-year-old male patient with poorly controlled HIV infection was recently diagnosed with cryptococcal meningitis. It is now 2 weeks since the initiation of intravenous IV liposomal amphotericin B and flucytosine therapy. MAT has responded well to treatment. His repeat CSF cultures turns negative. The opening pressures have normalized. MAT is being discharged today. So my question to you is, which of the options listed below would be the most appropriate recommendation for continuation of therapy for cryptococcal meningitis at home in MAT's clinical scenario? Would it be A. Discontinue flucytosine now, continue liposomal amphotericin B for an additional 28 days as consolidation therapy, followed by oral fluconazole as maintenance therapy for 8 weeks, or B. Discontinue flucytosine and liposomal amphotericin B now and initiate IV micafungin for 28 days as consolidation therapy, followed by oral fluconazole as maintenance therapy for 6 months, or C. Discontinue flucytosine now and continue liposomal amphotericin B for an additional 2 weeks as consolidation therapy, with no maintenance therapy, or would it be D. Discontinue flucytosine and liposomal amphotericin B now, initiate oral fluconazole for 8 weeks as consolidation therapy, followed by lower dose fluconazole as maintenance therapy for at least 6 to 12 months or until HIV is controlled? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Discontinue flucytosine and liposomal amphotericin B now, initiate oral fluconazole for 8 weeks as consolidation therapy, followed by lower dose fluconazole as maintenance therapy for at least 6 to 12 months or until HIV is controlled. Patients with HIV infection and cryptococcal meningitis should receive induction therapy with liposomal amphotericin B and flucytosine for at least 2 weeks, followed by fluconazole 400 mg orally daily as consolidation therapy for 8 weeks and fluconazole 200 mg orally daily as maintenance therapy for at least 6 to 12 months. Discontinuation of drug therapy for cryptococcal meningitis in patients with HIV infection should be contingent on control of HIV, i.e., undetectable viral load and CD4 count greater than 100 cells per millimeter cubed for 3 or more months. Please progress to the next question. And the next question reads, KJS, is a 12-day-old male patient born after 36 weeks gestation who was admitted to the NICU because of his low birth weight. KJS's mother is a healthy 30-year-old woman who was Group B streptococcus negative during prenatal screening. 10 days after admission to the NICU, KJS exhibited worsening of his clinical condition, with feeding difficulty, a bulging fontanelle, and fever. Due to concerns about new-onset meningitis, blood and cerebrospinal fluid samples were sent to the laboratory for culturing, and empiric antibiotic therapy will be started imminently by the neonatologist on call. So my question to you is, which of the regimens listed below would be the most appropriate empiric antibiotic combinations for KJS with suspected meningitis? Would it be A. vancomycin plus ciprofloxacin, or B. gentamicin plus ceftriaxone, or C. vancomycin plus cefepime, or would it be D. gentamicin plus ampicillin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. gentamicin plus ampicillin. The Infectious Diseases Society of America Bacterial Meningitis Guidelines recommend the use of ampicillin plus cefotaxime or ampicillin plus an aminoglycoside for patients less than 1 month old. Therefore, ampicillin plus gentamicin is the best choice for this neonate. Cefepime plus vancomycin provides an antimicrobial spectrum of activity that is excessively broad considering the probable pathogens in neonates with meningitis. Ceftriaxone plus gentamicin does not provide adequate coverage for listeria, which is a common cause of meningitis, so this combination is not a good choice for this neonate. Ciprofloxacin plus vancomycin is inappropriate for this neonate because of the toxicities associated with quinolone use, e.g., arthropathy, and tendinopathy. Please advance to the next question. And the next question reads, an antibiotic, known as BBD, is currently under development. It has the following properties: its protein binding is 5%, its molecular weight is 350 daltons. A value greater than 400 to 800 daltons is considered high. Log P partition coefficient, a positive value means that a molecule is lipophilic, a negative value indicates that a molecule is more hydrophilic. So my question to you is, which of the statements listed below concerning whether this antibiotic will be suitable for the treatment of meningitis and other central nervous system (CNS) infections based on its characteristics and probable pharmacokinetic and pharmacodynamic properties, i.e., ability to penetrate the blood-brain barrier in patients with CNS infections, is correct? Is it A. Drug BBD probably will not be a good candidate for the treatment of meningitis because its molecular weight is high and it is hydrophilic, or B. Drug BBD probably will be an option for the treatment of meningitis because its molecular weight is low, it is lipophilic, and it has minimal protein binding, or C. Drug BBD probably will not be a good candidate for the treatment of meningitis because it is lipophilic with low protein binding, or is it D. Drug BBD probably will be an option for the treatment of meningitis only because its protein binding is low? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Drug BBD probably will be an option for the treatment of meningitis because its molecular weight is low, it is lipophilic, and it has minimal protein binding. The main properties of a drug that promote penetration of the blood-brain barrier are lipophilicity, i.e., log P value, protein binding, the lower the better, although some antibiotics with high protein binding can still be used, and a low molecular weight. Drug BBD is lipophilic because it has a positive log P value equal to 2, low protein binding of 5%, and low molecular weight equal to 480 daltons. Therefore, it probably will be a candidate for the treatment of meningitis based on these properties. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 191.